Welcome to Let's Talk. Today we have with us some drug czars from Arkansas. We have John Kirtley, who is the director of the Arkansas Board of Pharmacy, and Kirk Lane, who is the Arkansas Drug Director. Welcome, gentlemen, to Let's Talk Jonesboro.
Thank you.
Now tell us, you've been around town all day today. I know you've visited Out of the Dark, which is a important mission for Jonesboro. Tell us what your message has been about today.
Go ahead, John.
All right. So a big part of the message that we've done today is talking about the opioid epidemic that we're facing, not just in Arkansas, but throughout the nation, but really focusing on Arkansas and some solutions to that potentially. We've talked a lot about naloxone, which is an option for people that are having an opioid overdose, and also talking about preparing for the Arkansas Drug Take-Back event that's happening April 28th.
And speaking of that, it's taking place in Jonesboro. I believe there are two locations. One's at Arkansas State University, and the other one is at the Jonesboro Police Department, where there is constantly a 24-hour bin to return expired drugs or drugs that you're not going to use. But what we're really dealing with today these days is an opioid epidemic, correct?
That's absolutely true. It's something that, when you look at the fact that there are more overdose deaths, exponentially every year, and the number of overdose deaths has actually reduced the overall life expectancy of people in the United States because of these unexpected deaths at lower ages, it's a shocking number.
Tell us, what are opioids?
Overall, opioids are generally thought of as pain medication. So a lot of the opioids that people think and are widely accepted in use are prescription drugs like hydrocodone or oxycodone, Percocet, Vicodin, Lortab, Lorcet, and then some other drugs like Demerol that are stronger, and even fentanyl. So if you hear fentanyl, there are prescription versions of fentanyl used in clinical settings or used as pain patches. But the thing you don't think about generally is that other opioids are heroin that you see on the street, and a lot of times what you think is heroin on the street is actually fentanyl also, which is a very potent opioid. Morphine is kind of the gold standard that most opioids are measured by. When you look at morphine and its potency, oxycodone is about 50% more potent than morphine. So 30 milligrams of oxycodone is about like 50 of morphine. One of the big worries we have, though, is illicit fentanyl. Fentanyl is 50 times stronger than most street heroin that we see, and it's 100 times stronger in some cases than morphine. So it is a very potent drug.
Now, I'm having two thoughts on this. I'm having the thought of prescription, is because all this sounds like prescription drugs, but you're talking about street value and street sales, and I believe I've read things of these things being produced in illegal labs maybe. Tell me how this has come about.
I'll weigh into that. So we know that there's over 177,000 illicit fentanyl labs in China. And China is one of the big producers of what they call illicit fentanyl. And fentanyl has had a pharmaceutical purpose in the United States for a number of years, usually for end-of-the-life instances or cancer when a patient can't swallow pills. Fentanyl can be absorbed through the skin. It can also become airborne and be inhaled. That's the danger of it, especially with illicit fentanyl. And as Dr. Kirtley said, it's 50 times more potent than heroin, and 100 times more potent in most cases than morphine. So to kind of give you a concept of that, and that's why I have this package. A package of Sweet and Low is equivalent, if you look at it, to a gram. And
okay.
the compound in the Sweet and Low is similar to fentanyl. So if I open this and I pour it out, the contents of that is 1 gram. So what does that mean? So what that means, in that same gram, if that was fentanyl, there would be 1,000 dosage units in there. But what the dangerous side of it is, there's 500 lethal doses in it. So this 1 gram, if this was fentanyl, could kill 500 people. And what's so dangerous about it, if you absorb it through it can be absorbed through the skin, or if it got airborne, it can kill people. It's lethal airborne. So again, 500 deaths from 1 gram of fentanyl.
My goodness.
The other problem with it is it's so cheap, where a kilo, what they talk about a kilo, 2.2 pounds, 1,000 grams, is usually anywhere between $1,700 and $5,500. Comparatively, a kilo of cocaine or methamphetamine may run you $16,000 to $20,000 depending on who you buy it from. So having extremely high lethal content and extremely cheap, and that's why we're seeing the influx into it. We talked about Arkansas per se has a prescribing rate of 114.6 prescriptions for every 100 people. The national average is 66.5. And so what that tells us is we have a very opioid dependent population. We're overprescribing, and that's the root of it. We've been over 100 prescriptions, in the 100 prescription range for several years. Even in 17, we'll be at probably 108. So we have to do more to affect that problem, because we know that when we have an opioid dependent population, that drug cartels, whether it be China or coming up through Mexico or through the Canadian trade routes, are going to target populations that have opioid because it's just good business. They're going to put that product in there. And when somebody is dealing with prescription drugs, especially the opioids, they have a tendency to work what they call that circle of addiction, and they may get to a point where they move from hydrocodone to oxycodone to Oxycontin, and then eventually to heroin, because sometimes people have a 20 to 30 pill a day habit, and at $1 a milligram on the street for what those pills are worth, if you do the math, usually it's the cost that drives people to heroin, or the interest of maybe chasing that high or trying to feel normal. And a lot of times we find that people don't start in prescription drugs to get high. It may have been some type of pain element from a surgery, or some type of prescribing injury from a doctor that led them into that circle. And they're trying to feel normal. They're trying to keep from withdrawing, and it just drives them deeper and deeper. And we're heroin because of the cheaper alternative. And what's scary about it is fentanyl is now being mixed with heroin, or being so marketed as heroin, and fentanyl is extremely deadly.
Fentanyl is not one that is not a drug name that takes me back through the years. When did it become something that's a concern? When did fentanyl become a concern?
Go ahead.
I think prescription fentanyl has always been a concern. We've, in law enforcement, and I'm sure in the medical, always took precautions in dealing with fentanyl patches, which were prescribed to patients. And I know Dr. Kirtley can tell you more about that, but illicit fentanyl has really been on the market for several years. It's really come forward now because, in America, we consume over 80% of the world's opioids for less than 5% of the population. So it's just good business, like I said earlier, for drug cartels to market their product to us.
And that's what people need to understand, is they're propping up cartels in other countries when
Absolutely.
that's one more bad reason to use drugs. But there's so many directions I think the conversation goes. Does fentanyl give you the high that, say, hydrocodone or cocaine or whatever?
One important thing to remember, whenever you're talking about opioids, people try to divide and have a bright line between the difference of street drugs and prescription drugs. But what you've got to understand is your body doesn't know the difference. They work in the exact same receptors in your body, and your body will react to them in the same manner. So a lot of false security for people is they think if it's a prescribed drug or a prescription drug from a pharmacy, prescribed by a physician or a nurse or a dentist, that they don't have to worry about addiction, or they don't think that you can get high from it. But that's a complete misconception. What you've got to understand is that your body can become addicted to prescription drugs in exactly the same manner as it would if you were using heroin, because it works in the same way on the same receptors.
Now, with that, though, there's a slippery slope of what a doctor needs to prescribe a patient in pain. And I think people have seen this. They have a loved one who's in their 80s maybe, and they're saying, what's the worst thing that can happen if this person becomes addicted to a drug? Is this something that you have to work with the doctors?
I think one of the misconceptions, there's a couple. One, doctors were giving bad information from Big Pharma in the 90s.
Okay.
We're dealing with that civilly now
Right.
with lawsuits from the AG and the cities and counties. But more importantly, that concept of trusting, we trust our doctors to give us good medication and concepts about prescribing. It's very important that we have that information to move forward on that, and that good information to keep us from that level of addiction that's out there.
Now, when you speak of the lawsuit, that's a lawsuit that I think 74 counties and more than 300 cities in Arkansas, at the request of Governor Hutchinson, have filed against Big Pharma, and I think we can expect to see something coming out of that in the next few years.
Yeah, it may take 4 or 5 years to weigh into that problem, but one thing we do know, Bill, is that, and I say this quite a bit now, is the house is on fire and we need to put it out. We need to stop pointing fingers at who's responsible for it. We can figure that out after, but we need to start saving lives. We need to start changing our habits and our prescribing habits, find non-addictive medications that are going to do the same thing, find alternatives to the opioids, and when we have to prescribe opioids, also prescribe them with a plan that may have naloxone, that may have some way of weaning that patient down for their own health. I think we as Americans, we require or we need to have good prescribing habits, and we depend on that from our doctors. We depend on that quality medication or that quality medical review to sustain a good, healthy, quality life.
Where does someone begin? Because I suspect someone's going to see this show and know subconsciously that this is me. They're talking about me right now, and it's going to create some stress in their body, and it's easy to give in. If you're an addict, it's easy to give in. What do you advise people to do when they realize I may be addicted to a prescription drug? Because it's hard to go to the doctor and say, hey, I want to give up this drug that I'm really addicted to.
You've got to look for resources. We've changed as society in a lot of ways where, for me, my grandparents, if they had a problem, they knew that they needed to go talk to someone that was a mentor, someone, it was their pastor or their deacon or something else. And we've gone from that to where it's almost shameful to discuss something with anybody else that's a struggle. So a lot of what we've gotten into is, you can take a pill for just about anything to fix a problem, which is it's frankly a lazy approach, but it's a more comfortable approach because you don't have to let down your guard and be vulnerable. So there are community resources all over the state. One of our websites, artakeback.org, we're trying to link those in and show people where they can go. But it may be talking to a friend, talking to a neighbor, talking to a counselor that has some expertise in drug and alcohol abuse, and it could be, seeking out help because it's going to be needed.
Are opioids bigger than traditional street drugs, marijuana, heroin?
I think so. I think we realize in Arkansas that methamphetamine is our #1 drug threat, but opioids is our #1 deadly threat. And opioids is growing extremely fast. It has already moved up to, I think, probably our #2 drug threat, just based on what we're seeing, the advances of it. Of course, we've always had problems with alcohol and marijuana that a lot of way are their gateway drugs. Whether people want to admit to them or not, they are. But trying to find ways to affect each one of those and how they all interrelate. We're seeing changes in the cartels of being able to supply whatever they have on hand. And in the past had probably been, well, this group mainly distributed cocaine and this group mainly distributed methamphetamine. Now they're very polydrug. And so they're utilizing those polydrug routes and the contacts they have to faster push that bad medicine to us.
You know, the really scary thing though is that, you know, overall the public always kind of thought that crack cocaine was dangerous. They always thought heroin was dangerous. You know, and marijuana even had some danger, some legal aspects associated with it. You know, when we're looking at statistics that say that, you know, 4 out of every 5 people using heroin started with pills, in a lot of ways it's because they think pills are safe. They just do not understand the risk that comes with prescription drugs is exactly the same as these street drugs. So it's almost scarier to think that people have let their guard down and they have no fear of pills, not realizing that it often leads to those street drugs that they're already scared of.
That's interesting. What do we have a rate? Do we know how many people in Arkansas have a drug problem, or is there any way to guesstimate?
I don't
those type
think
of
it
things?
is. I think one thing that we realize is data. Trying to solve 2018 problems on 2016 data is difficult, especially when there's resources, you know, now that we're seeing more resources come down from Washington, funding and whatnot, and try to apply that funding and those resources to those exact problems with old data is difficult. So that's one of the missions that we have, is trying to develop our data. And this problem, there's not a silver bullet to it. It's so multifaceted that it takes everybody working together to try to solve the problem. One, first, realizing that we have a problem and educating ourselves, and then moving into trying to solve that problem.
I know you guys have done a lot of training for police officers and first responders, maybe entirely. Tell us a little bit about what type of training you've done.
You know, we worked a naloxone program, and that's one of the things that we realized in dealing with parents. A lot of times came to us early on trying to find the best rehab or recovery center that their dollars could buy to put somebody in there. And they had the mindset that, you know, you got involved in this issue with drugs very quickly, and they wanted it to be solved very quickly, and you can't. It's a lifetime cure to this thing when somebody gets involved. So one of the things that we found out, and we told parents that, you know, if you have basically matches in your house, you need a fire extinguisher. You have somebody that's abusing opioids, you need naloxone, or Narcan as we call it. And so we realized very quickly that Narcan was a temporary solution to a problem that keeps people alive. It allows somebody to breathe during an opioid overdose. That we could train law enforcement, because law enforcement was the tip of the spear. A lot of times when they were coming in to contact people with fentanyl, there had already been some instances around the country where law enforcement officers had come into contact either by touch or by inhaling that got disseminated up into the air during an arrest, and those officers went down and had to be revived or saved with Narcan. And so one, we wanted to train those officers since they were the tip of the spear. Second, we wanted to save the community because now we had an effective temporary antidote to keep somebody breathing during an opioid overdose. And so the thing was to get the message out there, to buy the Narcan and to get it out there. We've since partnering with the Criminal Justice Institute in Little Rock with a lot of different police agencies. We've got over 3,000 dosages or kits out, or more than 3,000, actually 6,000 dosage units, because each kit comes with 2 dosage units. And we've got over 3,000 kits spread out across Arkansas, and building more kits based on federal funding, based on donation, based on state funding, private grants from Blue Cross, or the Blue and You Foundation, donated 1,300 kits to us, which was great. I think that was the group that actually donated to fund Jonesboro's program. True. And so we're hoping that those programs are going to go forward very quickly, and we can grow from those. But one thing to note, that since we have started the program in late 2016, when we had our first save, we've saved over 65 people so far, just with first responders. So we know it's a program that works. We're trying to add to that program. The Alcohol Drug Coordinating Council just appropriated $50,000 to build an online program. Not only can we train our law enforcement more effectively and more readily, but we can also train communities with that. And so we're working forward and pretty proud of that program to get it out. And again, probably be a model program for other states.
What can just the average person do? You know, everybody probably knows someone that they consider to have a drug problem. I think that's fairly common these days. What can the average person do to help if someone in need or a stranger even?
So, Bill, I'll give two examples. You know,
Okay.
if you have a loved one that you think does have a problem with alcohol or drugs, you need to talk to them about it. I know it's uncomfortable, and sometimes that's the kind of thing that hurts friendship a lot or hurts a family a lot. But the other thing is you've got to be willing to help them get whatever help that they need. So if you have someone and they said, well, I don't even know where I could go to an AA or an NA meeting or to counseling, then figure it out. Figure out where there's a meeting that you can help take them and go with them. You know, I think that, you know, Drug Director Lane and I have both done that in the past. You know, I've had friends that, you know, I thought had a drug problem, and when they finally said, you know what, I'll go to a meeting if you'll go, then you need to be willing to go with them. And it's amazing because, you know, we had to do that in pharmacy school. We had to go attend, you know, a couple of AA or NA meetings that were open, and shockingly, we saw people that looked like us when we got there. You know, it wasn't the people we expected to see, but it was the people that we looked just like.
Right.
You know, looked like my parents, looked like my friends, my college buddies. And what you realize pretty quickly is this is a disease. It doesn't care what you look like or who you are or what education you have. It's something that can affect any and all of us.
Right.
You know, the other thing is, you know, you've got to be cognizant. You've got to think about the fact of what is going on in someone's life. Because if you don't realize that that is what's going on, you may already have a friendship that's being destroyed because of the drugs, and it's an effort to do a stressful thing and try to help your friend.
Well, and because I think we're aware of the term a functioning alcoholic, that goes back, but I think there's
Absolutely.
probably a functioning opioid addict.
Right.
It's amazing to see. If you go into circles where you see people that are in recovery, it's amazing to see how broken their lives might have been, even though it might have looked successful on Facebook. You know, a lot of times I say fake book, not Facebook,
Right.
because it's the picture perfect thing that everyone sees.
Oh,
and
yeah.
you know, in my position with the State Board of Pharmacy, much like I believe, you know, Director Lane's position in law enforcement, you know, we've both seen some people on the very worst days of their lives, and it's something that can actually get to you a lot. But I think thankfully we've also both been able to see people that have come through this disease of addiction and gotten help and are back on the other side of it, and they're trying to help spread that word of there was help for me and there's help for you, and life can be a lot better.
That's right. Well, gentlemen, I want to thank you for being with us. Can you tell us where people can go for help? Is there a website? Is there a phone number? What,
Sure. You know, we're trying to develop a one-stop shop, and that's that www.artakeback.org. You can get resources on where the closest take-back site is to you, whether it's a one-day event that we got coming up on April 28th, or whether it's a sustained 24-hour take-back box. It has prevention resources in there for parents to understand what to look for, what the signs are, a whole series of resources from the CDC to SAMHSA and all the latest and greatest government entities to help us. It also has resources in there for recovery, where recovery centers are throughout Arkansas. And we're actually adding to it and developing a private portal for doctors in the future for them to get education and prescriber education, certified education from the CDC about the prescribing guidelines that we need to implement, and also alternative prescribing. So as we develop this website, we hope that people will share it and get that information out there to make a one-stop shop for where they need to go.
Very nice.
So, a couple more things.
Okay.
You know, it's an interesting point, Bill, that last week the Surgeon General actually made a call, the United States Surgeon General, on the public to be prepared for drug overdoses and to potentially consider carrying naloxone with them. You know, this is the same type of call that they haven't made it in years, but it's similar to saying, know how to give CPR in case someone needs CPR around
That's
you.
good,
Know
yeah.
how to give the Heimlich maneuver if someone is choking near you. Know how to pull out your phone and call 911 when someone is in distress. Naloxone is actually available directly to the public in pharmacies without a prescription, based on a statewide protocol developed through the Board of Pharmacy and agreed upon by the medical board. And for participating pharmacies, you can go in and simply say that either I'm at fear of having an overdose from an opioid, or I may come in contact with someone at risk for an opioid overdose. And if it's a participating pharmacy, they can sell it directly to you.
My goodness. Well, that shows us exactly how serious this problem is, and two, that's a good way for our people to be conscious and take ownership of solving this problem.
So in addition to the Arkansas Take Back event that's happening April 28th, later in the year, November 1st, we're going to have another Arkansas Prescription Drug Abuse Summit. This is an educational summit for members of the public, healthcare professionals, and law enforcement that was started and invented at the State Drug Director's office several years ago. And we've got a long list of partners, but we're looking forward to delivering that again this year.
Wonderful. Gentlemen, thank you for joining us on Let's Talk Jonesboro.
Thank you.
Thank you.